So thank you very much for joining our fifth dialogue on health security, hosted by Global Health Innovation Policy Program at GRIPS. My name is Hiromi Murakami, and I will be facilitating this dialogue series. And we're very honored to welcome a distinguished guest today from Canberra, Australia, Dr. Sanjaya Senanayake of Australian National University Medical School in this very important timing. As you know, Japan has been struggling to make COVID-19 under control, while Australia has been quite successful in containing COVID-19 situation. So we very much would like to hear how Dr. Senanayake views Australian approach in situations. The purpose of this dialogue series is to build a community for sharing information and knowledge and experience and discuss how best to prepare for future health crisis and build health resilience. We have seen a number of nations have started vaccinations, and Australia has just approved the Pfizer-BioNTech vaccine, and Australia is aiming to complete vaccination by October, I heard. The nation of 26 million people has reported fewer than 30,000 coronavirus cases, and death cases are a little over 900, which is small. So Dr. Senanayake will be sharing his view regarding Australian experience and effort to contain COVID-19. We'll have dialogue and Q&A in the remaining time, and Dr. Kurokawa, our director, will be joining later. So let me introduce today's speaker, Dr. Sanjaya Senanayake. He is an infectious disease physician in Canberra and an associate professor of medicine at the Australian National University Medical School. He has an interest in epidemiology and infections of public health importance, and he is a regular commentator in the media on a range of public health issues, including COVID-19. With that, I'd like to pass the microphone to Dr. Senanayake. We greatly appreciate that you taking time for us and sharing your view with us. Thank you. Go ahead.
Thank you, Romy, for the invitation to talk to such a distinguished audience about COVID in Australia. It's always a pleasure and always lovely to meet new friends and experts in this field. As you correctly said, we have to plan for future pandemics. It has been 100 years between major pandemics, so the 1918 Spanish flu and COVID-19. But since 1940, we've had over 300 new infections appear. And most of them have come from animals and into the human world. Now, only COVID and perhaps SARS in early 2003 really have had a major impact. I mean, possibly H1N1 in 2009. But there are lots of infections emerging all the time. So even though it was 100 years between this pandemic and the Spanish flu, it could be much, much less before the next one strikes. So it is important that as a global community, we learn lessons because of course we've seen the damaging social, economic and health impacts everywhere in the world from COVID-19. So in terms of my talking points today, for those of you who aren't too familiar with Australia and its political and health system, I'll go through that. And then I'll talk about Australia's COVID situation and the factors that I think helped us and possibly hindered us. And then probably we've had a few outbreaks in different parts of Australia, but the Melbourne outbreak, the metropolitan Melbourne outbreak, which began in the middle of the year, was probably the major feature of last year's COVID outbreak in Australia. So I'll talk about that and some of the lessons learned, and then specifically focus on hotel quarantine, which I think Japan and other countries around the world are struggling to get quite right. There was an interesting High Court case about political borders, which I'll touch on. And as Hiromi talked about, we're progressing with our vaccination program, our rollout program, and I'll discuss how that's been going so far. So this is Australia, has a population of just over 25 million. Now it's a federation, so we have a federal government and a number of state and territory governments. So I don't think my little point is working at the moment, but you can see Western Australia, the Northern Territory, South Australia, Queensland, New South Wales, Victoria, Tasmania. They've all got their own governments. They've either got a premier or a chief minister who is in charge. They have their own cabinets. But of course, federally, we have the Prime Minister of Australia, Scott Morrison, and the cabinet that he leads. Now, even though this vast land has 25.4 million people, about 14 million of those people are concentrated in just 4 cities. So Brisbane has 2.3 million, Melbourne has 4.9, Sydney has 5.2, and Perth 1.9 million. So even though there are lots of smaller cities and towns throughout Australia, the population of those towns and cities are very low. So you've got intense concentrations of the population in 4 major cities, and really almost half in Sydney and Melbourne alone. We have universal healthcare. We call it Medicare. That means that any permanent resident or Australian citizen can go to a major public hospital where they will receive free healthcare. So medications, tests, blood tests, radiology, all is free. And usually we have a private system, but usually the physicians and surgeons in hospitals in private practice will also work in the public system. So you usually, or we believe, you get a good overall standard of care in our public health system at no cost. Similarly, primary care is, GPs can charge, general practitioners can charge a little bit above the Medicare item number, but generally if people can't afford that, they can go and find GP practices who only charge the Medicare levy, so they're not out of pocket. So it's free healthcare, which meant during COVID as well that tests were largely free. So that made testing, incentivized it a lot more. We do have, as I said, quite a thriving private system, and the majority of that relates to elective surgery. So if someone doesn't want to wait a year for a hip or a knee replacement in the public system, they can have it the following week in the private system. But of course, the private system does cater for other kinds of patients too, but it's built on the backbone of elective surgery. Now, this is something I drew because I'm not very tech savvy, but also because this is a work in progress. I was just sitting down and trying to work out how the health notification system in Australia works. So I'm still seeking opinions from some of my colleagues, but I think this should give you, as people who don't live in Australia, an idea of how our health system works. On the left-hand side of the screen in green are the states and territories. As I said, they've got their own governments. You've got a health department who reports to a chief health officer who has been appointed by the government and who reports to the health minister. And the health minister of the state territory, of course, is part of the state cabinet. Federally, we have a similar system. We've got our federal health department. They're called the chief medical officer when it's for Australia, rather than the chief health officer, which is for a state or territory, who reports to the health minister, who in turn reports to federal cabinet. But in the middle, we've got these other groups. So we've got something called national cabinet, where the premiers and state ministers or chief ministers of the states and territories sit with the prime minister. Below them is the Australian Health Ministers Advisory Council, which all the health ministers from the states and territories and the federal health minister are members of. And very important for COVID, below them is something called the AHPPC, the Australian Health Protection Principal Committee. The membership of this comprises the chief health officers of the states and territories of Australia, and it is chaired by the Chief Medical Officer of Australia. Below the AHPPC, and I should add, a lot of the COVID guidance for Australia has come from the AHPPC. But the AHPPC isn't a fount of knowledge unto itself. It gets knowledge from a number of sources. So below it, we've got our Public Health Laboratory Network, who meet separately. You've got microbiologists from around the country who discuss issues relating to notifications, drug resistance in isolates, etc. Then you've got CDNA, the Communicable Diseases Network of Australia, who are typically public health experts. The organization which I'm a member of, ACID, the Australasian Society of Infectious Diseases, has a member sitting on CDNA, the Communicable Diseases Network of Australia. And the CDNA is responsible for writing something called a song. So it's not music. They don't burst into some strange rhythm. It's a series of national guidelines, the song. So for COVID, we've got a song. And when they update the guidelines, I like to say they've changed the lyrics. But yeah, that's what they do. So, and on top of that, we've got centers of excellence. So the Menzies Institute in the Northern Territory, the Doherty Institute in Melbourne, the JCSMR, which is the John Curtin School of Medical Research at the Australian National University, to which I'm affiliated, or with which I'm affiliated, as another center of excellence. And all these groups are feeding information to each other at different levels. And you can see the arrows that go back and forth. And I think that's been very useful. And Australia, though we're geographically very big, we're not a very big country in terms of population. So a lot of people know each other in the various fields, and I think that helps facilitate the transmission of information. And that's, say, different to it must be much harder in a place like the USA, which has 330 million people, to achieve that level of, I guess, professional intimacy.
Right.
Yes, and if we look at the epidemic curves for different countries around the world, you can see that Australia, as I said, unfortunately, I don't know how to use a pointer here. So, but hopefully you can see right at the bottom, the blue line is Australia, has a very low 7-day rolling averages of new confirmed cases per million people. So we're obviously, as a nation, very happy with that. It has made life a lot easier, although we've certainly had our troubles. This is something I drew up using various sources. COVID-19 cases per 1,000 population and COVID-19 deaths per 10,000 population. Just to give you an idea of how Australia stands, and Japan too. And you can see in both cases, Australia and Japan have done extremely well compared to Brazil, the United Kingdom, the United States, and South Africa. I did understand from the delegate list that we may have a Canadian delegate or two here. So unfortunately, I haven't included Canada in these graphs. But in terms of COVID-19 cases per 1,000 population, the top graph, Canada is about 20. So, and Canada is slightly larger than Australia, has about 50% more population. So they've got about 38 million people versus 25. So they've had 20 cases per 1,000 population of COVID. And in terms of deaths, it's about 5 cases per 10,000 population. So certainly not as low as Australia, Japan, New Zealand, but not as high as some of the other countries we're seeing on these graphs, like the UK, the US, and South Africa. And this is from our health department, Australia's COVID-19 overview. So as Hiromi said in her introduction, we've had under 30,000 cases as of around the 21st of January. So 28,730 cases, just under 200 active cases, and 909 total deaths. So if you can see the locally acquired in the last 24 hours, there have been 0 cases. And in fact, now, because I did this a few days ago, it's been about a week since Australia has had a case of community transmission of COVID, which obviously we're very happy about. We are still having a number of cases being acquired in the hotel quarantine system. And if you follow tennis, you'll know that we've got about 1,000 people being brought across for the Australian Open, staff and etc. At least 10 positive cases there. We've had no positive cases in Australia. In fact, if they get it from the Australian Open group, none in Australia, it'll team off, if you like tennis. So we had 32 at all. When the outbreak started, we it is also a distance, so it takes a certain amount of effort to get to Australia. If you're coming from Europe or the US, you're looking at about 24 hours door to door in terms of flight transits and various waiting experiences, etc. So it's a long trip. So you really have to want to come to Australia. It's not like it's a different Asia itself. Always find a way through if it's a hard border and you don't have to travel across water or travel by plane. So I think that's been one advantage for Australia and New Zealand. Now, population density I put up there. Look, I'm not so sure about this, but as I showed you in that map before, we've got this very large landmass. We've only got 25 million people, and that works out to about 3 people per square kilometer. And on that top graph with the mustard yellow numbers, they're the population densities of the various countries. So Japan has a population density of 347 per square kilometer. And again, Canada, which I didn't include in this graph, is about 4 people per square kilometer. So if you look at that, you can say, well, there doesn't seem to be a direct correlate between COVID cases and population density. But to me, it just seems intrinsically apparent that if you've got social distancing, physical distancing is so important, and you have people in a country where there's very low population density, it would just help the cause. But this graph shows that you don't have to have a low population density to have low rates of COVID, as with Japan and as with South Korea. And also Canada, which has had higher rates of COVID, has a similar population density to Australia, so 4 people per square kilometer. And I think part of the story and part of the confusion will be, as discussed, there is a concentration of people in Australia in only a few major cities. And Sydney, so if Australia has a population density of 4 per square kilometer, Sydney has almost 500 times that, 1,900 people per square kilometer. Melbourne has 1,500 people per square kilometer, ranked 936th and 955th in the world in a particular survey that was done. So this is, up till May last year, what Australia did and how Australia responded to the COVID outbreak. And this is the result that we are seeing here. When COVID came out and we realized it was in the epicenter seemed to be China, Wuhan in particular, the first international blockage or blockade was for arrivals from China. Now, this had a downstream effect, a huge downstream effect on our university system. Australia has about 700,000 overseas students coming here every year or enrolled in university, which is an enormous source of income and, of course, a number of other cultural, intercultural benefits as well, but certainly economic benefits. And of those, I think China contributes maybe 200 to 250,000. Don't hold me to those numbers, but I think that's right. So very large numbers and a lot of income and all the cultural and other benefits that go with it. So that was lost. And I guess like a lot of the world, we didn't recognize that, yes, we're seeing cases in China, but there's a lot of asymptomatic travel, there's a lot of mildly sick people, and there's so much travel around the world that it would have spread to a number of countries already. And of course, we know from testing sewage samples and testing serum samples that some parts of Europe seem to have had COVID back in December. But so really, rather than that staggered approach, if we were going to close the borders, if we had another pandemic, what we did on the 20th of March, if you look to the 19th of March and go up, on the 20th of March, the Australian borders closed to everyone. And if we'd done that earlier, we might have had an even smaller epidemic curve. And then the federal government, through National Cabinet, enacted a number of shutdowns, which were unprecedented, but they seemed to work. And you can see by the end of April, our epidemic curve had come down. So it had taken about 5 or 6 weeks for these interventions to make a difference. And that's consistent from what I recall with Wuhan, where when they went into lockdown, we didn't see an immediate improvement within 2 weeks, but around 4 to 6 weeks later, we saw an impact in these measures. And then we started in early May to ease the restrictions. And we'll talk about that later. But I think an early closing of the borders made a difference. And of course, you can also see by late March, early April, we were quarantining all arrivals as well. So leadership, I think, is very important. During a pandemic, where we're talking about economic and health gloom and doom, people are afraid and they look to their leaders, their political leaders. They want to see their leaders giving them a plan, giving them hope. I think that is so fundamentally important. And it's certainly early on in Australia, we had that through a mechanism called National Cabinet. Prior to National Cabinet, we had, as you can see in the first line, something called the Council of Australian Governments, COAG. And they would meet not that frequently. Now, I'm not a political expert, but I think a couple of times a year, but not that frequently. And you would have the Prime Minister and the Chief Ministers and Premiers meeting in one group, the Health Ministers meeting in another, etc. But that was replaced by National Cabinet. And I think you saw on that, I'll go back, on my poorly hand-drawn effort, right at the top in the middle, National Cabinet. This is where the Prime Minister, the Chief Ministers and Premiers of the states and territories met, and they were meeting frequently, very regularly at the start of this outbreak. And you can see, because of physical distancing, they were meeting via teleconference. So that's Prime Minister Scott Morrison sitting down at the table, and in the background on those screens are the leaders of the various states and territories. And what we found was that we were having these leaders at the end of these meetings coming out and saying, this is our plan for Australia, this is why we were doing it. And I think it was very inspiring and stabilizing, and gave the Australian public some degree of security in very uncertain times. And I think we can contrast that to some other countries where maybe the US, where perhaps we didn't see that. And of course, if you've got 50 state governors, getting them all around the table and getting all their opinions many times a week or a couple of times a week or once every fortnight is almost impossible. but I think for Australia, this worked really well. And they were initially united. Now, cracks have started to appear. At Victoria and New South Wales, there were issues about school closures, and more recently, there have been disagreements about border closures, which I will touch on later. But generally, National Cabinet has worked very well. Oh, and the other important thing about National Cabinet is that the people knew that the decisions that were being made were based on health advice from their Chief Medical Officer of the Federation of Australia and by the Chief Health Officers of the states and territories. So not only were we getting united political leadership saying the same thing, or largely the same thing at the start, but we knew that they were getting their advice from health experts. So that made us very happy. And we know in some parts of the world that hasn't always been the case. So how do you keep people at home who need to work, who need to get out there, need to travel to work, need to mix with people to do their job to earn money? When we shut down or locked down, the government introduced an unprecedented program called JobKeeper, which still exists in a different version at the moment. And JobKeeper cost $130 billion over 6 months. So this is for wealthy countries. If you are a wealthy country like Japan, like the UK, like the US, like Canada, you can afford to do this. Employees would not have to turn up to work, and they would be paid $1,500 a fortnight. Now, for some people, that's less than what they were getting before, but for a lot of people, it was more than what they were getting. So there are a lot of people who are getting $1,000 a fortnight, turning up and doing a hard shift at work in a cafe or restaurant, who now were able to stay at home and get 50% more for doing nothing. So it was a very interesting concept, but it worked well. It supported businesses. So I'm not an economic expert, but it supported businesses. It kept businesses afloat. It gave people an income. They could still spend money on other goods and services. So all this kept the economy going, although the economy, of course, was suppressed compared to what it normally would be. And of course, the other thing it did is it meant people were comfortable at staying at home. They didn't have to rush out and get into contact with other people. So it did help physical distancing as well. So COVID-19 testing in Australia, as I mentioned, it is free of charge. I think I've had 3 COVID tests myself, and all free of charge, and all been negative, I should add. But Australia certainly was very good and has been, continues to be pretty good when it comes to testing. Early on in the outbreak, we had one of the highest testing rates in the world. If you look now on Our World in Data and those other websites, we're similar to a lot of other countries like the US, etc. But of course, they've got a lot more disease burden. But certainly early on, we had a lot more testing than many parts of the world. And that was done through testing in general practice. We created a number of centers for testing, drive-through centers, mobile centers when there were outbreaks. So ambulances, vans would go around to suburbs that were in hotspots and offer testing. Where I am in Canberra, we built, I think it's about a $20 million facility in an oval across the road from the hospital, which was going to be for surge capacity if people got hospitalized, but when that didn't eventuate, it's been turned into a testing center. Might even be used for vaccinations as well. Australia generally has done well with testing. And as you know, the World Health Organization recommends that you have less than 5% of your tests being positive before you get worried that you're not capturing enough cases. So if you've got 10% or 20% positivity, that means you've got such a high disease burden in your community, you're missing cases. Australia has never been anywhere near that. So the highest you can see is the second from below Victoria, 0.5%, and that really surged during their mid-year outbreak. But generally, Australia has had very low percentages of tests. So we've been fairly comfortable that we're capturing and identifying people with COVID. And we initially used a nasopharyngeal test. So this is where you put the swab right to the back of the nose, which is nasopharynx, which is quite unpleasant. But a few months ago, we changed to a high nasal swab and a throat swab, which is definitely more palatable. I guess literally palatable, but more palatable. The not so good stuff, technology. I think Japan is well known for its technology, and I'm not sure what Japan has used, but I'm sure you've done a very good job with technology. I know South Korea, during their outbreaks, have used technology very well. We had an app called the COVID Safe app. It's still there. It probably wasn't as successful as we wanted. So as you can see from that headline, after many, many months, it was just responsible for detecting 17 contacts in all the outbreaks and cases that we had. So it wasn't that successful. And there were some technical glitches with it, which apparently have now been updated. So hopefully it will be used a bit more. But really, after initially it got uploaded or downloaded by lots of people onto their phone, we initially got about 6 million people fairly quickly. I think it's come out to about 7 million people, and it's sort of plateaued there. The other thing in Australia is that you can't, by law, force someone to download an app. So it's all voluntary as well, which makes it a little bit harder. On the right, the other, I guess, unfortunate incident that took place was with a cruise ship. And in Japan, you had a cruise ship. I think that was the Diamond Princess from memory off the coast of Yokohama. We had the Ruby Princess off the coast of New South Wales. And due to an unfortunate set of circumstances, passengers were let off that boat and went to various parts of Australia with COVID. So I think we ended up having almost 700 cases of COVID from that particular ship, and a number of deaths as well associated with that. So I think that's one of the things in retrospect, treat cruise ships just like you treat aeroplanes. I'll now focus on the Metropolitan Melbourne outbreak. So we've had a few little outbreaks, but the Metropolitan Melbourne outbreak was the major one. So as you can see, again, I apologize for not having a little pointer, but in the middle, or the second big curve for Australia is related to COVID-19 in Metropolitan Melbourne and the state of Victoria, but predominantly Metropolitan Melbourne. It was a very big outbreak, and it contributed to a number of cases and deaths for our Australian numbers. So on May 25th, I don't know if you remember in that earlier curve, when we got to May in Australia, we were reducing restrictions. The numbers were low, but in Melbourne, they were still getting cases of community transmission. They were low numbers, but they were still there. But in May 25th, a staff member at one of the quarantine hotels, Rydges on Swanston, was positive to COVID-19. Then 2 others became positive. But 2 days later, the Department of Health and Human Services in Victoria recognised the outbreak, which ended up growing to involve 17 people, that particular group, with hotel workers and people in the household and social network of the case getting infected. And this happened just as Melbourne was reducing its restrictions. So stage 3 restrictions were reduced on June the 1st. So the timing was unfortunate. And these are the sorts of restrictions that it was being reduced to. So more than 20 people could be up to 20 people could be in your home at any one time. 20 people for indoor and outdoor gatherings at weddings, swimming pools, etc. 20 people in restaurants, cafes, and pubs. So, which in retrospect, as this outbreak was just starting to grow, was unfortunate timing. By June 14th, at another hotel in Melbourne, so the Stamford Plaza, different hotel, we had a staff member test positive for COVID-19. 3 days later, the outbreak was recognized by the Department of Health and Human Services. And again, there was a further easing of restrictions. So again, unfortunate timing, although, because as you can see in the second line of that report, because of the new COVID cases, restrictions weren't eased to the same degree. So they did recognize that there was a problem and they were nervous about easing restrictions too much. By the 24th of June, there had been a request for 850 Australian Defence Force, so military personnel, to replace private security at hotel quarantine. And we'll talk about that later in my talk. But then the Department of Justice and Community Safety said they would take over the program. Then 2 days later, we had this big headline saying 30% of travellers in hotel quarantine are refusing tests, which surprised everyone. We assumed that everyone in hotel quarantine would be having the tests that they were being asked to do, but 30% were refusing to do them. So that was a worry. On the 29th of June, hotspot Melbourne suburbs, which had been identified by the health department, had to return to a full lockdown. International flights were diverted because of concerns of hotel quarantine and breaches there. And then the next day, an inquiry into hotel quarantine was announced. By the 4th of July, they had a hard lockdown in 9 public housing towers. Now, this was, from a public relations point of view, not very good. These were public housing towers that involve people of low socioeconomic backgrounds, migrants as well. This was done at short notice. Delivery of information and groceries, etc., was criticized at a number of levels. So again, I think if it was done again, they would do things differently, I suspect. And this was also the first day since March that more than 100 days of COVID were reported over a 24-hour period in Australia. By the 6th of July, for the first time in 100 years, the Victoria-New South Wales border shut. So Victoria and New South Wales, the 2 biggest states in Australia, shut their borders for the first time. A huge thing. 2 days later, Melbourne and Mitchell Shire, which basically is Melbourne, went into lockdown for 6 weeks. So the city of about 5 million people went into lockdown for what they thought was going to be 6 weeks. Early July, the Victorian outbreak had spilt over into Sydney, so into New South Wales. Despite closing the borders, someone had gotten through. And this led to a cluster of cases in Sydney and an outbreak there, which they successfully managed, and we'll talk about too. By the 20th of July, they had the inquiry into hotel quarantine beginning. The 23rd of July, this was the first time that the mandatory wearing of masks happened in Australia, I believe, in Victoria. And on the 5th of August, we got the highest number of daily cases we've seen during this outbreak, which was 725. And I can tell you at that time, people were very, very scared that rather than get better, this was going to get worse. And of course, we suspected the lockdown would work, as we knew from an earlier experience in Australia, and we'd seen in places like Italy and Wuhan, but we also knew that it would take many weeks, and people were worried, and it was a very scary time throughout Australia. The 11th of August, then the governments at a Victorian and federal level were disagreeing about whether Defence Force support was offered or not to hotel quarantine. And then we got the genomics done, which said that 99% of the active cases in Victoria stemmed from those 2 hotel outbreaks. So really just 2 cases in those 2 hotels led to the large number, the thousands of cases we saw in this Victorian outbreak. By the 25th of September, the Victorian Premier apologises, and on the 26th of September, the Victorian Health Minister resigned, who was I think the only cabinet minister at a state or federal level who has done so since this outbreak has begun in Australia. Victoria put together a roadmap for reopening based on modelling figures, and it was justified. The modelling that they used to create this roadmap seems to have been justified because it worked. And as you can see, there's a first step, second step, third step, last step, and a COVID normal. So the last step, COVID normal, is when we have no new cases for 28 days statewide in Victoria, no active cases, no outbreaks of concerns in other states or territories. So this was Victoria, not Australia. And really, if you look again at the Australian curve, it mirrors what happened in Victoria, because Victoria was really responsible for COVID activity during that period. And you can see right now, it's much, much better. So then on the 9th of November, there was a ring of steel, that's what it was called, that separated metropolitan Melbourne from rural Victoria. That was lifted. There was a 25-kilometre travel limit that was lifted, and things started to return to normal. But at the end of it, we'd had an outbreak in Melbourne that had involved the whole community. It involved schools, it involved abattoirs, residential aged care facilities, and hospitals. So in the end, the Metropolitan Melbourne outbreak accounted for more than 60% of all Australia's COVID cases and more than 80% of deaths. So it was a very significant part of the COVID story in Australia. And most deaths were from aged care facilities. And about 75% of COVID-19 deaths in Australia were from aged care facilities. And there was also a national aged care inquiry into aged care facilities, which looked at how we can improve the safety of our aged care residents from infections like COVID. So lessons learned, we talked about the lessons learned from the Australian response. What about the lessons learned from this Metropolitan Melbourne response? So we can look at contact tracing, centralisation, healthcare setting, infections, lockdown, elimination, and hotel quarantine. Let's look at contact tracing. Victoria was criticised for its contact tracing ability. And it was compared to New South Wales, which is unfortunate because there's a great rivalry between New South Wales and Victoria. So they're always being compared with each other. But what New South Wales has, which is where Sydney is the capital, it has a decentralised system. So you do have a central health department, but you have public health units in the suburbs. So you've got smaller groups, they're more mobile, who know their suburbs, they know their populations, they know the places, they understand infection transmission more in their particular public health units. At least that's the idea. And New South Wales has shown time and time again that they're very good at managing outbreaks. So when they had a case spill over from the Melbourne metropolitan outbreak, it did lead to a number of geographical clusters of smaller outbreaks, but it never got out of control to the level it did in Melbourne, and they shut it down. And they actually did it without making masks mandatory. It was only in the most recent outbreak that they had in northern Sydney, in the northern beaches in December, that eventually masks were made mandatory. So that's what New South Wales did. And Victoria, on the other hand, was centralised. It didn't have public health units in various suburbs. And there's also a criticism, as you can see, on that headline, the news headline. They were using very much a pen and paper and fax system, but they've now had an overhaul of that, and it's more an electronic-based system. So now Victoria, and to their credit, they seem to be in a much better position. They're in a position that they're now, I believe, starting to get some public health units more decentralized, and they can trace contacts of contacts. That is the boast that has been made. So they're in a much better position. And looking at that, how they've managed a recent outbreak in December, they've certainly done a very good job. So healthcare workers, the one fear with COVID was that it would overwhelm hospitals, and not only would patients die, but healthcare workers would get infected. We certainly saw that in Victoria. So 3,561 healthcare worker infections were documented, 73% in the healthcare settings, 14.6% not in the healthcare settings. And in those healthcare settings, almost 2/3 were in aged care facilities, which is scary because, of course, you've got aged care residents who are the ones who get sick and die from COVID. Just over a quarter were in hospital settings and 8% in other settings. And of those healthcare setting acquisitions, 50% were aged care or disability nurses, 40% nurses or midwives, and about 5% were doctors. And interestingly, 609 non-clinical workers were infected in healthcare settings. I haven't seen the breakdown, but I imagine this would be ward clerks and orderlies, etc. Elimination versus suppression. So you are probably all familiar with these definitions, but I'll just go through them again if that's okay. Eradication, having no infection in the world. Elimination, having no infection in a geographical area while it exists. And control, accepting a certain level of circulating infection. Now, we took elimination as being no community transmission of COVID from an unlinked source for 28 days. Now, I initially didn't think that elimination was going to be possible, but throughout most of last year, most states in Australia had achieved elimination. South Australia, New South Wales, South Australia, ACT, the Northern Territory, Western Australia, they had met that definition. But what had worried me is that places like Melbourne and Sydney had not, because they're such large cities with high population densities. You've got certain populations which are less well educated, where English may not be their primary language, they're not getting the same media messages as the rest of Australia are getting. That worried me that COVID could be circulating in those large cities. The beauty of elimination, it would mean in Australia, people could move freely without borders, without worrying. But the problem was we were still having overseas travelers who've got a lot of COVID coming into Australia who could spill COVID into the community. And if you look at all our outbreaks, even the most recent ones, and even the one in New Zealand that's occurred, I don't think they've confirmed it in New Zealand, but they suspect that it is related to hotel quarantine. And all ours are related to overseas travelers either in hotel quarantine or maybe someone who was exempt or staying at home, such as flight crews, letting it into the community. But Victoria, Melbourne, had 50 days with no community transmission. They well and truly met the elimination definition. And I was very pleased. I didn't think they could achieve it. But in December, they had another cluster, which was related to a cluster that arose in Sydney. So again, if you have COVID in the world, you can have elimination, but only for a period of time. Without vaccinations, it is very likely that you will have outbreaks of COVID. You will have periods of elimination, but it will be punctuated by periods of COVID. Now, vaccination, if you have a good plan, will take care of that, and hopefully you can have a more permanent state of elimination. Melbourne hotel quarantine was an issue. There was a number of issues. So we've got photos of guards falling asleep on the job. Now, there are various subtleties in terms of infection control. Should the guard be within a meter of a person? Should they shake hands? Should they transport them? Various things. But I think we'd all agree that no one should be having sex with the people that you're meant to be looking after in hotel quarantine. That's not very good from an infection control point of view and a number of other levels. So the main issue there that came out was that private security firms were running hotel quarantine, and it was less than ideal, and maybe we should have used, maybe they should have used defence forces in Victoria. Now, we have used our defence forces in Australia. I'm not sure if they have in Japan or other countries. As of August last year, almost 3,500 Defence Force, soldiers, medical staff, logistical staff were supporting the states and territories. New South Wales and Queensland both had them being used to assist with hotel quarantine. And there was a national review for hotel quarantine as well. Now, our overall percentage of positive people was less than 1% as of October last year, coming in from overseas to hotel quarantine. But that wasn't stratified according to the different countries. I suspect if you look at the US and certain European countries, you would see much higher percentages. Now, hotel quarantine, the review basically came out and said that yes, quarantine is a power that's given to the Commonwealth, but it was given from the Commonwealth to the states and territories to run during COVID-19. It's also an expensive resource that comes at a high cost to the individual's social and economic well-being. And they made a number of recommendations, making hotel quarantine a better experience, developing different options for travelers based on stratification of risk. So people coming from low-risk countries where there's no COVID, could they potentially have home quarantine for a shorter period of time? Those sorts of issues. And I'll briefly talk about this. We had a big High Court case in Australia where the man on the bottom right, who's a businessman, a former senator, but a prominent businessman, Clive Palmer, along with the federal government, had a court case against the governments of Western Australia and Queensland about the closing of their borders. I think from a federal point of view, if you want the economy to run, you like to see all the borders open and free movement of people and goods between different states and territories. But Western Australia and Queensland wanted to protect their own populations from COVID and felt the best way to do this was by keeping the borders closed. So this led to a historic court case in the High Court of Australia. And at the center of it was Section 92 of the Constitution on the imposition of uniform duties of customs, trade, commerce, and intercourse amongst the states, whether by means of internal carriage or ocean navigation, shall be absolutely free. So this was tested in the court of law. But Western Australia won the case. It was deemed that Western Australia had the right to close its political borders. So that was a big decision and showed how powerful the states and territories are when it comes to protecting their own borders when compared to the Commonwealth. So that was a real eye-opener. And finally, we've got the vaccination rollout. I believe I've gotten so enthusiastic I've gone over time, so I won't talk too much about our vaccination program, but I'm happy to answer them in any questions. But our vaccine rollout will happen next month, hopefully. We had contracts with 4 vaccines. We were pinning a lot of hopes on the University of Queensland vaccine at the bottom. But unfortunately, due to a glitch where people were testing HIV positive participants who received the vaccine, even though they didn't have HIV, because they used a protein of HIV in making their molecular clamp technology, which meant that participants were testing positive for HIV, even though they didn't. It meant that this vaccine, which probably was going to work very well against COVID, had to be stopped. So we're relying really on Pfizer, Oxford AstraZeneca at the moment. Novavax is a protein subunit vaccine where the phase 3 results should be available by the middle of this year, and hopefully that will be a very good vaccine. In animal studies, it's shown that it stopped infection completely. But as you all know, animal studies don't always translate to human studies. And Australia is part of the COVAX program as well. So my key messages: be an island. Of course, if you're not an island, well, it's difficult to do that unless you're Superman or the Hulk. Put in early travel restrictions. Have united leadership to calm your populace and give them a sense of security. And the political leaders should listen to the health advice from health authorities. And if that happens, the public will engage in what you want them to do, and that will make your life easier. They'll do the testing, they'll be compliant with physical distancing, and I think that's largely what's happened in Australia. Economic tools like JobKeeper not only help the economy, but also help physical distancing. Keep testing, use technology, which we haven't been that good at, mandatory masks during COVID-19 outbreaks. Consider a decentralized public health model. If you've got a large area, there are some advantages. Periods of elimination are possible, but without the vaccine, permanent elimination is unlikely. So hotel quarantine lets COVID-19 get into Japan or to Canada, Australia, from other parts of the world, so get it right. And regional political leaders may not realize that they could have stronger powers than their central government counterparts, as this court case about political borders showed. So this is me when we started our COVID-19 war hospital, and thankfully we didn't have many. So thank you, and I apologize for going over time.
Thank you so much. It was very comprehensive and very informative, and we have very good information about, how Australia dealt with this COVID-19 crisis.
I'm glad you enjoyed the talk. Thank you.
And if anybody who wants to ask questions, you can send us questions with the Q&A column. Otherwise, I will ask one question. I loved your drawing of the, all the organizations.
Yes.
I wonder, is it already existed before this COVID-19 crisis, or because of some of the organization may have been coordinated because of the COVID-19? Or I want to know how, all those organizations well coordinated and, make such a decisive, decisions and, lead up to leadership, clear communication to, constituents. And that seems to work pretty well, which is not often the case in different countries. So I wonder if this organization or coordination was already existed or just built because of this.
Yes, no, very, very good question. In fact, I think you can now see my little arrow cursor. I think, is it moving? Excellent, good. So look, this was largely in place in Australia. So I'm just thinking the only new thing is the National Cabinet, which arose last year. Otherwise, all these organizations, all these structures have been in place. And as I said, Australia, 25 million people, so not a big population. People tend to know each other. There's good networking. So there is a lot of communication back and forth along these lines. So this is largely an existing health infrastructure. Excellent.
And then your leadership, the political leaders, seems to be very decisive, or very, get together and have, a consensus, informed by scientific experts, and seems like a very, top of the time. How was it possible? Because a lot of nations are struggling with economic situation, or should we stop this, pandemic, and they're, struggling, but it seems like Australian leaders dealt quite well. And then I know that, high popularity for Mr. Scott Morrison. So
yes.
Why do you think that was possible?
Okay, I really do think a lot of that is because of this structure, because when the premiers and chief ministers of the states and the prime minister go to National Cabinet, they're going with information from here, from their chief health officers and their chief medical officers. And it's largely, they're getting largely the same information and the same recommendations. So they're going to that National Cabinet meeting well informed and probably all wanting to do relatively the same things. Now, there have been, as I said, some cracks. There are some issues. Some states wanted to close schools, some didn't. The biggest one was the court case, where the federal government and Clive Palmer, the businessman, had the court case about closing the political borders of Western Australia and Queensland. But interestingly, after the initial court case, the federal government withdrew from the court case. So I think almost as a show of goodwill. So there have been some issues, but generally people have agreed at National Cabinet. The leaders have agreed because they're getting the same information from their health authorities. And of course, the other thing is this: National Cabinet is just in its infancy. And I suspect the leaders are more likely to agree on things like a pandemic. When it comes down to when the pandemic goes and National Cabinet talks about defense and health and all those other things, there might be a few more disagreements.
Okay.
Okay, we have one question from audience. He said, how about coronavirus mutation in Australia?
Yes, no, that's a very good question. So I think that the audience member is asking potentially about the UK and South African strains, Brazilian strains, etc. We've certainly had the UK strain here, and we've had, and I can't tell you the numbers, and we've had the South African strain here. Now, they've both been in hotel quarantine, but the UK strain was associated with an outbreak very recently in Brisbane. So a city, the capital of Queensland, over 2 million people. So there was a case there where a worker in hotel quarantine got infected with the UK strain. And now she had been out and about for 5 days in different parts of the city while infectious. And given all the hype that we heard from the Northern Hemisphere about this strain, it was very worrying. And in fact, Queensland, Brisbane, the city of Brisbane went into a lockdown for 3 days because it was the UK strain and this particular person had been out and about 5 days. But guess what? They got on top of the outbreak very quickly. I think only a couple of this person's very close contacts got infected. And it is very interesting because when I first heard that this UK strain was it was more infectious, my first thought was, yes, it seems to be causing a lot of infections in the UK, but the UK isn't having as good a time as some other places in managing COVID. What will happen if the UK strain comes to a place where they're fairly good and experienced at managing COVID? And yeah, when it came to Australia, we seemed to get on top of it. And it's also borne out by the Public Health England data. So they found that if 100 people were infected with COVID that wasn't the UK strain, they'd go on to infect about 10 people. But if 100 people got infected with the UK strain of COVID, they'd go on to infect more people, but only a few more, only 15 people. So 15 people versus 10. So it seems to be more infectious, but not dramatically more so. The South African strain, as far as I'm aware, hasn't caused any community transmission in Australia. And I don't think we've had the P1 Brazilian strain here yet. And although you have had that in Japan from travelers, didn't you, who recently came from the Amazonas, I think, region of Japan. So it'd be interesting to see how that goes, because that's got the E484K mutation, I believe, which makes people's antibody responses a bit lower to COVID than to other strains.
All right, good.
So, Dr. Kurokawa?
Yeah, I think a few things. I think your testing means testing is PCR, I suppose, right?
Yes, that is correct.
Yeah, now where this PCR was done? In the university or some health, some specific places?
Okay, so usually the big hospitals in certainly the city centers, all our big public hospitals would do COVID testing. So the big laboratories, the bigger hospitals would do COVID testing. We had obviously major reference laboratories which could do higher loads of testing, etc.
Okay, so this COVID testing means PCR.
PCR, and I should add that also in Canberra, one of the private pathology firms also ended up doing COVID testing.
Right. So that's a PCR, right?
All PCR, yes. So no
and also you'll be picking up some sequencing too to discover mutation, right?
So yes, but the sequencing is not done as widely. So it's only done,
sure.
a couple of
So
tests.
that where the sequencing are done.
So the sequencing is done in Melbourne. So there's a big center in Melbourne that does it. I think there's a big center in Western Australia that does it, and in Sydney. So not many places do it.
Right. So that maybe three places, I think you send picking up some of the samples and testing, right? Sequencing, right? All the time.
Yes.
That's good, right? All right. And also, I think your sort of emergent sort of structure as a government has worked very well this time.
Yes, that's
so national cabinet thing, right?
Yes. So I think it has been good.
So that I think if in retrospect, I think what percentage of general public has gone to study or just at least testing PCR and sequencing? PCR at least.
Or how many people in Australia?
Yeah, of entire population. Just guessing.
Look, I think it's about 10 million tests, the last thing I saw. So maybe, and some people have done more than one test, but I think it's over 10 million tests out of a population of 25 million.
Okay, so about, that means what, 5% or so? I don't know, what is it?
So, well, 10 million, so I guess almost half, if it was just a single person who had it, almost half the population.
Okay, all right, about half the population were covered in a way.
Yes.
All right, that's good. I think Japan was very small, but I think earlier they just recognized mortality rate seems very low, so that I think they are not really passionate in covering everybody, like your case.
Yes.
And also entire population is smaller in Australia, so that may be one factor, which was good compared to Japan. Right. So that I think some of the sort of engagement and also response to Corona in Australia it's a big island, but I think that was one factor, but worked reasonably well and much better than perhaps Japan. But as far as mortality is concerned, Japan seems weak because we are now being hit by the third wave, which is larger than first wave and second wave. So I think we really have to reflect on what we should have done when something happens again. Much maybe mutation somewhere, which may be stronger, or maybe next wave of certain flu type of whatever epidemics or pandemics. So I'm really pushing the Japanese government to say, and that's fortunately or unfortunately become a pandemic, so that why don't you listen and learn from the better strategy and action by other countries? Because now if you Google Corona and you just have some country's name, and there's a sort of wave or sequence of things happened in, let's say, Sweden, Australia, and Japan are quite different, quite visible. So I think we really have to learn the lesson from this pandemic. That's my argument.
No, it's very well. I'm a very lazy person. I don't like to create something new if someone's already done a very good job before me. So I don't like to reinvent the wheel. I would happily take what someone has done and if it works well and use it.
Right.
But I'm also very keen to see what other countries are doing and what has worked.
Yes. So I'm just asking somebody to have this, just try it, different countries in the website and Corona and name the country. And you see this graph, which is very beautiful. That's a time that we can utilize in this hyper-connected world.
Yes.
I think, the information that Dr. Sananake has given us is very, very, good information. So I think a lot of hint that I think Japan can learn from, and especially testing and also the leadership and also the organization and, all those things. I think still Japan can learn, and I hope the Japanese leadership will listen. And having, had this Australian successful case, I think we have many lessons learned. And if anybody wants to have any question, otherwise we'll be closing this session. And I greatly appreciate Dr. Sanjaya Sananake for sharing your views. This is very informative, constructive view, and a lot of things we can learn from our Australian case. And I greatly appreciate that. Thank you very much.
All right. Thank you, Sanjay. Thank you.
Thank you for
Enjoyed
us.
it very much.
Thank you very much. I enjoyed giving the talk.
Yeah,
Thank
great.
you.
Thank you.
Thank you so much. Thank you, everyone.
All right. Thank you.